Okay.
Can I start my
Yes.
Good evening,
Yes.
everyone. I extend my warm welcome to everyone who has joined for this webinar, which is on allergic eye disease, which is titled as Itchy Burny Eyes. First of all, I would like to thank Dr. Satyan Deka for initiating this webinar on a monthly basis because it's a great platform for everybody to share their experience and have great learning. And for today's webinar, we have our esteemed chairperson, Professor Dr. Ratul Deka sir and Dr. Swaraj Bhattacharya sir. We have another chairperson who's yet to join, Professor Dr. Rumadas Debsikta. And it's my privilege to introduce the panelists for the evening. We have Dr. Arundhati Tamuli and Dr. Kalyan Das sir. Himanta Hazarika sir is yet to join. So let's not waste much time because we are already late. So let us move to the topic itself. For this, I would like to invite Dr. Arundhati Thakur ma'am. She is a cornea anterior segment refractive surgeon associated with LASIK Laser Eye Center. And we don't need much introduction. She's well known to us. We know her expertise in her field. Over to you, ma'am.
Thank you, Nalakshi, for the kind words. Good evening, everyone. At the outset, I'd like to apologize for the technical glitch for which we are starting a little late. I'll try to make up the time. And good evening, the respected chairperson, Surajda, Ratulda, and of course, Ruma Baido, and my esteemed panelists, Kalyanda, Arundhati, Nilakshi, you are no less in this field. And of course, Satyanda and Nilanjan for making me a part of OSA and this academic forum. Hope we can do some learning on itchy, burny eyes. The topic that you've given me, which actually encompasses a lot of diseases, but we need to just concentrate on the ones we mostly see. Can I have my next slide? So when we say itchy, burny eyes, most of these cases will come with one predominant sign is the redness. And when we see such a patient, there are a whole spectrum of diseases which can be responsible for this redness, which could be from a simple bacterial conjunctivitis, viral, seasonal allergic conjunctivitis. There could be a medicamentous, dry eye, rosacea, ulcer, and a lot of other allergic diseases. Can we go on to the next slide? So, whenever we are treating or even evaluating such a patient, the first component, which is very important, is taking an excellent medical history. And the importance of this cannot be overemphasized because often these patients are trying to tell us something about their problem. And to understand it better, at times we have to lead them with certain helpful or leading questions like when do the symptoms occur, when do you feel worse or better, and is there a time at which you get the symptoms, or these are just intermittent? And you as the patient talks, you need to think about the probable etiologic condition. And then of course you have to put in leading questions like, is there an itch, burn, ache, or blur, because each of these symptoms has a significance. And then, of course, a family history of similar disease or ocular conditions is always useful, and a family history of any allergy. And then other metabolic diseases like thyroid, diabetes, skin disease, and certain autoimmune diseases, if preparation, if elicited, helps in the diagnosis. Next, please. So when we come to the differential diagnosis, we have to first form the foundation of the red eye treatment, and we have to initiate a correct diagnosis in order to initiate appropriate treatment, because sometimes it is seen that inappropriate treatment can lead to various side effects which will not only mask the presenting symptoms but also give rise to a lot of complication. And this, if done accurately in the systematic format, is often very quickly done to have a diagnosis. Can I have the next slide? So, whenever you're examining such a patient, the critical components of diagnosing a patient with red eye is, besides a slit lamp examination, we need to flip the eyelids. Now, in the upper eyelid, we often check for follicles or any papillary reactions, if there are any vesicles, any viral papillary reaction on the lid margins. or any modified cells in the upper lid margin. And of course, we should repeat the procedure in the lower cul-de-sac too. For this, we need to pull the lower eyelid and give a check to look for pseudomembranes, any scarring of the conjunctiva, any foreshortening of the fornix if present. Of course, thickness of the lower lid also will give you an information of what the patient is going through. Next slide. So there was another slide. I think we need to go one slide back. Okay, go to the next slide. So what I mean to say, when you examine the upper lids, as you can see, in these two patients, one is a very upper red colored upper lid retraction. That is the papilla. And of course, here you can see a slightly palish one. This is the follicle. Now, it is very necessary for all examining under slit lamp to differentiate between what is a papilla or what is a follicle. Papilla is usually very red and they're micro in size to begin with, and the base is very pale. In the other hand, follicle has a very pale top and the base is very red, and often you might see opening of a blood vessel in the center of a follicle. Now, presence of papilla and follicle will help you differentiate what kind of disease the person is suffering from, and in severe cases, these papilla may coalesce or enlarge in size and have what you have, the giant papillary conjunctivitis. And certain follicles also may be enlarged over time if the patient is not adequately treated. Second, next slide. So, okay, the color of the conjunctiva as we go on with the slit lamp examination is very important, whether it is a very dark hue or it is a pale pinkish hue. Both these features, when you pick up on a slit lamp examination, further helps you to lead to your diagnosis. Next slide. So coming to the, after examining the lids and the conjunctiva, we come to the limbus. Now, this is a very important site that you need to examine, because in the limbus, you'll see if there's any presence of arcus and any embryotoxin. If there, you can see the patterns of palisades of Vogt. Sometimes in certain diseases, these palisades are often obstructed or obtunded, and you do not see the clear pattern. They might be neovascular, and if you need neovascularization, then you need to ask a previous history. There might be marginal infiltrates. You may look at limbal vessels come inside. They may be attached to certain dot-like structures, what we look for, the Tranter's dot, and the pattern of corneal infiltrates within the mid-peripheral region of the cornea also gives you an indication that the patient must be suffering from some kind of an autoimmune disease. So examination of the limbus is very important before you go on to examine the cornea. Can I have the next slide, please? So whenever you're seeing these patients of the eyes coming with red or burny eyes, you'll see these people will often have a discharge or watering. So it is very essential to look at the pattern of this watering or discharge. Is it thick? It is stingy, rope-like, or watery, or is it just minimal or plentiful? And sometimes you might see there are some clear opaque discharges in the eyelids. So whenever you see such patient, it is always mandatory to give a check, a total body check in this patient, for which you just need to take a step back and look at the patient, observe the hand and the face. Often you will pick up some signs like in this patient, as you can see, the patient has acne rosacea. And of course, patients may have rheumatoid arthritis and various atopic or skin conditions or seborrhea, which may help you come to the diagnosis faster. Can I go to the next slide? So whenever you find these pictures, then you need to think logically as to all these symptoms and signs are leading to where. If there is an intense itching of the eye, and that is the predominant symptom, we usually think of allergies. Now, if the patient complains of intense burning, it may be associated allergy, but then you often think of dry eye disease or any of the causes for it. And if you see that the eye often feels sticky and there's a discharge, we think on the line of infections like in bacterial conjunctivitis. Next slide, please. Whatever be your evaluations, the three big things which we often come across is the bacterial conjunctivitis, allergic conjunctivitis, and dry eye. These are the three main big players of the itchy, burning eyes. And today I want to address the conjunctivitis part of it, the allergic conjunctivitis. Can I go to the next slide? So, allergic eye disease is very common and it affects 15 to 20% of the world population. And strangely, the numbers are increasing with increasing pollution and modernization and the increase of urbanization. And patients with having one form of ocular or any other allergic disease is bound to have an ocular allergy too. The rate is said to be as high as 7 out of 10. Any person having a systemic allergy is bound to have an ocular allergy. Can I go to the next? So, brief pathology. See, whenever a person is exposed to an antigen, the first exposure is to the tears and it absorbs onto the cornea. And when it and enters the cornea, it excites the T cells and the B cells, and these incite a host of immunological reaction. Can I go to the next slide? And then ultimately, when this is treated, it goes on to sensitize the mast cells and keep the memory of this antigen in the mast cells. So whenever the person gets exposed to the same antigen in the second time or further time, then there is an increased hypersensitivity reaction, and this gives rise to a release of lot of mediators of inflammation like histamine, heparin, chymase, and tryptophan, and these again go on to incite the blood vessels to release the eosinophils and basophils, which again on its own like secretes a host of other immunotransmitters. Can I go to the next slide? And like leukotrienes, cytokine, and prostaglandins, and they in turn go on to incite a late allergic response, which is called the type 4 hypersensitivity reaction, which makes the patient a chronic allergy patient or a person who becomes repeatedly responsive to this allergy. Can I go to the next slide? So when we talk of allergy, we need to address two issues. It's a plain allergy where the patient is just hypersensitive to certain thing and it is mostly harmless to the person. However, the other end of the allergic eye disease is atopy. Here we have an extremely hypersensitive person who has a hereditary predisposition to allergic disease and often has systemic diseases which makes him prone to this atopy. Can I go to the next slide? So when we classify allergic disease, there's a whole spectrum. We have the seasonal allergic conjunctivitis, which is called the SAC, the perennial allergic conjunctivitis, the keratoconjunctivitis or VKC, which we see very commonly. Atopic keratoconjunctivitis, it says to be present in 3% of the population. It is not so uncommon because we have seen in our clinical practice what we think is VKC advances. Some of the cases are in fact AKC, which has been treated as VKC in the past. And of course, giant papillary conjunctivitis, though it is a finding, it has a special spectrum under the allergy because certain conditions which may not be associated with allergy but gives rise to GPC, and of course, drug-induced dermoconjunctivitis, which is commonly seen especially in patients being treated with long-term topical anti-glaucoma therapy. Can I go to the next slide? So when we talk of allergic conjunctivitis, this is the common picture that we see, a pinkish reddish conjunctiva. Often there is chemosis of the conjunctiva with associated lid swellings. Can we go to the next slide? So these are usually, whether it's seasonal or perennial, it is usually caused by environmental factors and most common in genetically predisposed patients. You'll find a family history in such cases, but and often, you might not find any other diagnostic test positive. And you'll find there is hyperemia, chemosis, lid swelling, there might be a mucus discharge, and of course, there is itching and tearing. Can I go to the next slide? And most common allergens that we are responsible for this is the indoor allergens, which could be dandruff, hair, or mites in the curtains or rugs. And of course, when these patients are exposed to pollen or dust of the environment, it often gets aggravated and makes the condition worse. Can I go to the next slide? Even NSAIDs were used, but they are not given preferences. Even NSAIDs were used, but they are not given preferences. Can I go to the next slide? Nowadays, as we have seen that they often lead to refractory to the treatment and often gives rise to the complications. Next slide. So the most important part of treating these patients is counseling of not only of the patient, because sometimes most of the time we see children are affected with it. You need to counsel the parents too. And prime importance is maintaining lid hygiene at all time and avoiding eye rubbing. So the patient should be counseled about frequent hand washing. And if the symptoms are very intense, then often cold compresses help elevating some of the symptoms. And these kind of patients, when exposed to the environment, they're always advised to wear goggles or some kind of a cap to avoid direct exposure to the inciting agents. Next. So, if the patients come with mild to moderate symptoms, antihistaminic mast cell stabilizers are the mainstay. They are usually OD or BD doses, and they can be, if it's mild and moderate, can be kept up to a maximum period of 3 months. And after that, we need to give a stop and then repeat if necessary. And in certain cases, if the patient is very symptomatic, mild low potency topical steroids can be started not more than 4 times a day, and it has to be tapered over a period of 3 weeks, not to repeat if it occurs again without consulting the doctor. And of course, lubricating eye drops, preferably preservative free, can be used, which not only helps to wash away the allergens but gives a comfort to the patient. Next. Now, in severe cases, it is often a potent steroid is advised in high dose and high frequency, and this should be given as a pulse therapy up to for a period of 10 days and gradually tapered over a period of 3 days. And of course, the antihistamine mast cell stabilizers can continue after 3 months and can repeat. And in severe cases, we do advise cyclosporin eye drop in a BD dose, which can go on to from 6 years, even up to a year. And lubricating eye drops also continue. Next. So coming to the vernal keratoconjunctivitis, which we see quite often here in our parts of the country too. Next. Now, what is it is a chronic bilateral, but at times asymmetrical, seasonal exacerbation of allergic inflammation involving the ocular surface. Now, mostly it affects the tarsal, but we see involvement of the bulbar conjunctiva, and it is most commonly seen in children and young adults from the age of less than 10 years to around 20 years or even beyond. The youngest patient affected by this disease, as reported in the literature, is a 5 months old baby. And some of these patients have an atopic background. And what is very characteristic of these patients is these symptoms are very much common in summers as compared to in winters. Next. Whenever you're seeing a patient with VKC, we often divide them into whether it's a palpable type, which is the most common and affects the upper tarsal conjunctiva. It could be limbal, most commonly seen in Asian and blacks. And of course, it can be mixed. And most of our OPD patients come with a mixed presentation of this disease. Next. Now, based on the constellation of typical clinical signs and symptoms, the characteristic feature of VKC, there is intense itching. The patient will often, like itch with his fists around the eye. There is photophobia, there is a mucus discharge, there is redness. Often you see the sclera is not as white and it will have a dirty sclera kind of a look. And there is very frequent blinking as the patient cannot tolerate the light of when we examine in with slit lamp. And of course, when we examine most of the severe cases, you might find SPKs which may be sparse or even diffuse and coalesce together. Upper eyelids may have follicles and papilla, and often in severe cases, you'll see the giant papilla on the upper tarsal. If you see the limbus, you'll see the nodules. And of course, when you come and examine the cornea, you may see varying grades of Shields also. Next. So these are the conjunctival signs. You see a diffuse hyperemia, and it is seen throughout the eye, and it has a pinkish color, giving a dirty scleral look, as you can see in the first photograph. And often you will find at the limbus there is pigment dispersion, and the palisades of Vogt are not clearly seen. The giant papilla, as you can see, and in chronic cases, often you will find there is obliteration of the limbus, and there is scarring all throughout the limbus. Next. And if you see carefully in severe cases, you might see some white gelatinous excrescences at the limbus, which are shiny, and these are called the Horner Truntus dots. And if they become advanced, they coalesce and increase in size and give a sago kind of an appearance. And these, when seen, are very characteristics of VKC. Next. Now, coming to the cornea, as I said, you may see few SPKs, dryness, lack of luster of the cornea, and it may also go on to involve and have SPKs. And of course, with the presence of GPC, which is constantly causing a mechanical friction, you may have the shield ulcer, or which may start as a small epithelial defect and may go on to increase and have a plaque, as you can see in the last picture, which is a very characteristic grade for shield ulcer. Can I go to the next slide? So the corneal involvement, as I said, there is a total obliteration of the limbus here with scarring. And when such a condition happens, there is increased astigmatism. Sometimes because of the rubbing and this scarring, it may lead to keratoconus or even keratoglobus, and you may have other marginal disorders. This sign, when it's present, it is often called a pseudoxerontoxin. Now, if this is not treated and allowed to advance, it will go on to form a pannus all over the cornea. And if it involves the entire cornea and involves the limbus, we have what is called the limbal stem cell deficiency, where any remnant of the limbus is lost. Next. So when you want to treat these patients, we need to classify them as mild, moderate intermittent, moderate chronic, severe or blinding. Now, this is actually very well explained in an article by Dr. Nikhil Gokhale, which came as far back in the IGO issue of 2016. But when it comes to treating VKC, this is one of the most cited articles worldwide. So it always helps if you take this as your guide in your treatment of VKC. Next slide. So the main line of topical treatment is either antihistaminics, mast cell stabilizers, but it's always preferable to have one with dual action. Corticosteroids are there in topical form. Of course, immunomodulators have come as a big line in this treatment. And of course, preservative-free tear substitutes constitutes as a mainstay of treatment. Next. Coming to other immunomodulators that have found place are cyclosporin A, which is found in 0.5 and 1% strength commercially. But in very severe cases, we might have to reconstitute 2% eye drop from the injectable form so that the disease is controlled. And tacrolimus, which started as a skin ointment, is available as eye ointment now as 0.03%. But however, in severe cases, we might still have to use the skin ointment around the eyelid to control the features. And these two have become the mainstay in the treatment of severe VKC in today's practice. Next. So sometimes most of these patients need concurrent systemic therapy, which can be an antihistaminic. In very severe cases, there are trials which have come out now, especially Dr. Sayan Basu's group. They are treating as a first line with systemic steroids so that immediately the symptoms are controlled and the patients enjoy very long gaps of symptom-free periods. And of course, in very severe cases, even systemic immunotherapy has to be started. Next. So coming to the mild disease, they usually present as redness and itching. There is congestion. You may see fine velvety papilla in the upper tarsal conjunctiva. Often there is no corneal involvement. So here, what we often counsel for allergen avoidance, lubricants, antihistaminic muscle stabilizers. So we have just broken this as ALHM because these things keep repeating. So you know that this will always follow. And what is important to know that if there is no corneal involvement, it is not necessary to start steroids at this stage of the disease. Usually, with these, the patients, get control of their symptoms and the disease. Next. Now, moderate, it could be intermittent or chronic. Here you will find corneal involvement in the form of SPKs, which may coalesce. They may be fine punctate erosions, Horner's drought, limbal inflammation, and there may be limbal thickening of less than 6 clock hours. Now, in addition to your avoidance of allergen lubricating and antihistaminic mast cell stabilizers, if it's intermittent, a mild soft steroid like a loteprednol may help. And of course, it has to be given for a period of not more than 3 weeks and tapered over, not to repeat. However, if these patients come with a chronic presentation, it is always advisable to start a cyclosporin eye drop at a dose of 0.5% strength and keep the person on this for 3 to 6 months at least and take a call on your follow-ups. Next. If the patient has severe disease, the patient will have large active cobblestones, which often coalesce and have erosions in the form of keratitis. There may be micro erosions or macro erosion. There is severe limbal inflammation and involves more than 6 clock hours. You may often see a pannus growing in, and there might be areas of post-inflammatory scarring in other parts of cornea. Here we need to start potent topical steroids, nothing less than prednisolone acetate, high dose at 6 times and as a pulse therapy of 10 days and quickly tapered over the next 3 weeks. And of course, here it is always advisable to go for topical cyclosporin 1%, which is actually commercially available now. Next slide. Now, if the patient has started blinding disease, there's extremely active large cobblestones, there's even the presence of shield ulcer, severe annular limbal inflammation, and you are starting to see signs of limbal stem cell deficiency, which can present as extensive conjunctivalization, extensive limbal scarring, or even corneal scarring. Next. Now, though the disease after a certain point becomes self-limiting, there are certain conditions which do not respond to your maximum medical therapy, most common of which is the giant papillary conjunctiva. Earlier, cryoablation was practiced, but then it leads to severe scarring of the upper tarsal conjunctiva, so it is best avoided now. So what most refractory to supratarsal steroids, if these GPCs are, often it may help to excite these GPCs and put an amniotic membrane graft for proper healing and lack of scarring. And of course, if you see shield ulcers like this, it often helps to do a superficial keratectomy and put an amniotic membrane or a bandage contact lens to enhance healing. This BCL or amniotic membrane would stop these papilla from creating friction here and help this ulcer to heal. And of course, if you have severe limbal stem cell deficiency, then various procedures has to be done to restore the ocular surface, like a limbal stem cell transplantation. And while doing these procedures, concurrent medical therapy should be continued. Next. Now, coming to the other, it's the atopic keratoconjunctivitis. This is the more severe form of the allergic eye disease. Can I go to the next? So these are often seen in patients with associated bronchial asthma, atopic dermatitis, allergic rhinitis, patients with urticaria, angioedema, some kind of food allergy, or other severe ocular allergic diseases. Next. Now, as I said, the cause is always a genetic predisposition in a person who has a tendency which is aggravated by various environmental factors also. Now, these atopic compared to VKC is found in older individuals, usually around the age of 20 to 50 years of age. And in these patients, if we test, we'll find elevated levels of eosinophil and other lymphocytes and mast cells. The predominant sign is itching, redness, extreme photophobia. You will find keratopathy, SPKs, ulcers. These patients are often associated with keratoconus due to intense eye rubbing. They may have anterior polar cataracts also because of concurrent and repeated use of steroids also. There'll be thick mucus discharges, and often the lids are affected because of the rubbing, and you might find atopic blepharitis too. Next. So discharge, itching, and lid swelling is very common. And here, the topical therapy is similar to the one we use for VKC, but in AKC patients, the mainstay of therapy is systemic therapy for the primary inciting disease. Only if that is controlled, you will get control over your ocular symptoms. Next. So giant papillary conjunctivitis, as you can see here, the rest of the corneas are, this is an acute stage redness and a lot of fiery papillae. And of course, this is in a later stage. Next slide. Now, GPC, it happens because of repeated mechanical irritation, which can be caused by an edge of a contact lens, an exposed suture, a extruded scleral buckle, some cyanoacrylate adhesive if it has been used and the patient has lost the bandaged contact lens, or some foreign body which has been lodged. And if such a person is of an allergic nature, then the disease or the situation worsens, and there is a lot of chronic inflammatory cells if you see the conjunctival swab. Now, these patients often have blurred vision. If they are often intolerant to contact lens, also you'll see in long-term contact lens wearers, they often get a foreign body sensation, and you will see small uniform papillae on the upper tarsal conjunctiva, and there is often buildup of mucus around these papillae. Now, treatment is directed as removal of the causative or the inciting factor, which is the mainstay, along with lubricants, which often helps to heal. In certain severe cases, you might need a short spell of soft steroids to combat the inflammatory signs. Next. So, in coming to this summary of all these allergic disease, I mean, a proper history and examination is very much necessary, looking for the telltale signs and arriving at a diagnosis as to which category this patient falls into. Once you make a diagnosis, all efforts must be made to give maximum symptomatic relief to the patient so that the patient is agreeable to continue with the treatment. And you have to be aware of the complications of the disease, because if this disease is not treated properly, it can lead to severe complications that we have seen. And of course, sometimes there may be complications of the medications too, especially when you're dealing with steroids. So a treating doctor should not only be aware of the disease, but also the complications of the medications he or she has initiated. And the patient needs a lot of counseling in every visit, because often you find that these patients are going from doctors to doctors because they are not getting relief. So counseling is the mainstay of this patient, that you have to emphasize on completing the therapy as prescribed and coming for the regular checkup, so that we can ensure longer symptom-free periods in the course of the treatment. And in all your efforts, I think you have to maintain the functional integrity of the eye. And if your disease is controlled, you have to make sure that you can restore whatever functional integrity is lost, so that, as we have seen in VKC, usually the children are affected. These are the prime growing years, and they have a lot of dropout from schools. So you need to maintain the visual and functional integrity of the eye so that they can grow up to healthy individuals in the future. Can I have the next slide? Thank you for the pleasant for the patient list.
Thank you, ma'am. That was indeed a wonderful presentation. We all know that Allergic eye disease is often an enigma for the ophthalmologist. Often it's a very common condition, but as it mimics a number of other conditions of the ocular surface, it is often misdiagnosed or inadequately treated. So, Arundhati ma'am has rightly pointed out, she has very nicely explained the different subtypes, the clinical features, the management, and the complications that are associated with the conditions. So now I would like to request the panelists if they have something more to add on this. Arundhati Baidu, Tamli Baidu, if you have something else to add.
Hello. Yeah, very nice presentation, Arundhatiba. So, Arundhatiba, I really want to know about the drug-induced dermoconjunctivitis, which we get with the anti-glaucoma medication. Especially, I'm getting lots of patients, especially the patient who are on brimonidine. They get lot of this of conjunctivitis, and even if we stop that, and it really takes long to control. I have a patient like whenever I switch from brimonidine to different group of anti-glaucoma, even then they started these things, it continues. So in this type of patient, how to go with that? In those patients, we cannot give steroid also like.
So I think that's why I said in situations where you cannot give steroids, cyclosporin helps a lot because well, I think these patients you need to treat along with your glaucoma consultation. So if a soft steroid is allowed, at least in low dose, for a short spell to induce the action of the cyclosporin, then you can keep these patients on cyclosporin and lubrication. It often helps.
Because one of my patients, she initially developed allergic conjunctivitis with the this brimonidine. Then I switch off that brimonidine. I switch her over to a different anti-glaucoma medication. With that also, she again after a certain period she started developing that thing. So I started with little amount of steroid, but it got controlled. But I didn't start go ahead with this calcineurin inhibitor like cyclosporine, but I think that will help her.
Because once you start with steroids, you're getting the reduction in inflammation. You need to start concurrently with the cyclosporin because cyclosporin is safe, you can continue. Steroid, you're going to use limitedly. You just need to maximize the benefit for the spell that you're using. So often you will find, and because I think we as treating cornea specialists, we are not allowed to temper with the anti-glaucoma medicine. So because we would rather ask our glaucoma colleagues what are the alternative that you can give. And of course, in those cases, I would start a lubricating because what happens I have seen, because whenever the glaucoma colleagues are treating, it's often one drug or two drug, and the whole focus is on the control of IOP, the disc, and the OCTs. Often the telltale signs of ocular surface damage which is happening is missed. And then when they come with the chronic redness, often starting a cyclosporin alone does not help. So in consultation, if you at least can start a soft steroid 4 times daily, even for a week, I think it helps for the cyclosporin to start initiating its action. And of course, cyclosporin we can maintain even up to 1 year without any problem.
Thank you.
I have one question, ma'am.
Yeah.
So whenever we have kind of an ulcer, particularly the shield ulcer, what would be your approach in the treatment of these patients? Like whether you would directly go and start the steroids or put a bandage contact lens, or would you like to rule out infective keratitis in these patients? Because mostly these patients, they belong to a lower.
And since you're scraping off, if you take a smear and send it, it's often sterile. like you can see surrounding cornea is clear.
Yes.
There
If
is
it's clear, then it's like
and repeatedly putting the patient onto potent steroid is more harmful than with con- patients, you always put it in the lid margins, like how you put kajal after and in the very bad cases where it's coming like end stage, you have to start systemic steroids on and
of choice to start with.
Vaisala?
Uh,
Is maintained in a very low dose, which is like doable. We are seeing good results, and it is quite safe. We just repeat the blood parameters every 3 months. So
This is a very important point, I think. And refractive error also.
that also, and then avoid certain like food. Might have to repeat many times. So it's better to start with the softer steroid because it has just milder form or the moderate form of the disease. But once it's severe, I think then there's no point toying with a soft steroid and then going to a potent steroid. If you're dealing with severe disease, if you're dealing with blinding disease, you have to hit and you have to hit hard.
Direct with the prednisone.
Hit hard, if necessary, even with systemic steroids.
Yeah, I have a question regarding a sign. Conjunctival melanosis is frequently seen in PSC, and there is often a question how these melanosis will clear up. We don't actually, particularly me, I am not following up these cases for a long duration and all. What's your comment and how when it clears up?
It will clear up only when the disease is totally eradicated from that, because the melanosis, what you say, these are the palisades of Vogt in the limbus, which has been totally obstructed because of the disease process. So there is
And also in the font also.
yeah, because they would migrate, no, because of that. And
Yeah.
if you there was a paper by Dr. S.K. Rao long time back from Chennai. He said if you find, they have found it in the carankle also, a few pigments
Yes.
in. So
Yeah.
if you find it, that is a telltale sign of a VKC in this child in the past. Some will never have a dirty, that dirty sclera will never clear because in the severe cases, But some, as the disease progresses and the patient is weaned out of the disease, you might see some clearance, but certain telltale signs somewhere will remain.
Yeah, it's in fact the pathognomonic sign of VKC, the conjunctival hyperemia.
That's the
Ma'am,
that's
I have one question. Even though VKC, though particularly in those refractory cases of VKC, even it's a kind of a local allergy, but we know that somehow it's a some kind of a response of the immune system,
yes.
the systemic immune system. So, what is your take on should we treat these patients just as a local disease, or we should go into the root cause and then refer them to an immunologist and find out what exactly is happening and do the various kind of either the patch test or the various other allergy tests that are available, and then also take their opinion in the in our management.
Yes, in the moderate to severe, I think it's always helpful to give, subject them to a test, So what are they sensitive to? And for atopy cases, we are doing it. So for VKC also we need to do it. And then, as you rightly address it, there is a systemic phenomenon going on which is reflecting in the eye. That is why the San Basus group is, targeting with systemic steroids in the first go, and they're getting very good results. In fact, he's also telling me do it, but we are a little reserved because if the person just goes and disappears with the systemic steroid, I do not have a follow up despite counseling. then I think I need to be a little more brave, maybe one or two cases, but actually they're getting very good results. Because as I said, like if you want to kill them strong and first in the same go.
Correct. Thank you. Ma'am, another question. Since
Dr.
allopatidine is the
Kalyan Das
most
is also here. Can we hear from here? Dr. Kalyan Das, panelist is here. So
yeah,
can we hear from him also?
Yes, Dr. Kalyan, this question is for you. Since allopatidine is the most common molecule that is used for so long, and there have been, sorry, Dr. Das, are you there? I think he's not responding.
Yeah.
Dr. Kalyan Das, are you there?
Dada is there, but I don't know why his
I
name is
think there's
here.
some connectivity issues. So, anyway, it's a question which is open for all. So, allopatidine, regarding that, we have some literature points out that long-term use of allopatidine can cause some amount of dryness. So, how long can we put these patients on allopatidine, or if there is any dosage difference between the children and the adult?
No, I think olapatidine is, if you're dealing with mild cases, it's fine. Once a day, Pataday that you're using, and then of course you have the thing. But if you're dealing with moderate to severe cases, where the must stabilizers are the main thing, then more than olapatidine, you need sodium chromoglycate. Sodium
Yes.
chromoglycate, or it stings, no doubt about, but that works wonderfully. And you still get sodium chromoglycate. Earlier it was a QID dose, now it's in the ID dose because it's in, the sodium chromoglycate in the fourth form. So just twice daily application and it does wonderful to these cases, more than that. Because once the allergic condition is controlled, the rest is very easily taken care of. And if you're going to use Saturday or what you said, olopatadine, then I think 6 weeks is good enough if you see control. If we see that not much response, then 3 months and not beyond, because it's when you see the dryness, and then and because you're not expecting that drug to take care of the entire spectrum. You have to put the steroid, you have to put the cyclosporin. And if you find that, because instead of putting the patient in multiple drugs, that is when you are sure to have a fallout of treatment. So initially, when you load them for 1 month, it is always better to keep them on the mainstay drugs. Lubricating, cyclosporin, tacrolimus. This is what we are keeping these children in, and they're doing fine because lubricating is what they use. They even take to school, and cyclosporin is BD dose. Morning and coming at home, and tacrolimus is at bedtime, and the disease is much controlled.
Thank you, ma'am.
I have a question. I'm Dr. Nilanjan. Like, Madam Baido, regarding bipotestin.
Yeah.
So, what is your view on that? And number one. Number two, tacrolimus, treating VKC is a big challenge. So, actually, their patient is frustrated. We are frustrated sometimes. So, regarding the use of loteprednol, can we use it for low strength? Can we use it for a longer time?
Not advisable. When your action is got by cyclosporin and tacrolimus, that is what we are trying to emphasize. Steroid was the main line for a few years ago. Now you have immunomodulators, which is working wonderfully without any side effects. So you go for them. And of course, you need to counsel, because see, once you make the patient comfortable with steroid, even if you ask them to stop, they know that this drugs, elevates my symptoms. They will go on using it on the sly. Then you find they come with glaucoma, they come with cataracts, they come with other conditions. Don't let them get used to the steroids. Just use it when you want it to initiate your immunosuppression action and continue it with your immunomodulators. Because it takes 2 weeks time for it to start acting. So in this 2 weeks, you're just playing with your steroids to, induce the remission. So once steroid induces the remission, cyclosporin takes over from that. And tacrolimus maintains it.
And your views regarding bipotestin, like how that?
You can use BB dose. But it depends on what stage you're using. These are in the mild or early moderate stage, which is intermittent. If you're finding more perennial moderate disease, go for sodium chromoglycate.
And one more thing, sodium chromoglycate is not so much available in the market
It is the
now. That it supplies to market.
Alchem is there. Actually, it depends.
Okay,
If you're not
okay.
using it, they'll not give it. So in all the pharmacies near where I practice, they all have sodium chromoglycate.
Okay.
Chromal 4.
Yes.
Yeah,
Chromal 4, yes.
It's a very, very old molecule, and
Yes.
But very good, very good.
yeah, it's working wonderful. Ma'am, one more question. For those very bad refractory cases with GPCs, what is your experience on with supratarsal steroids? What is your drug of choice in the dosage?
No, drug of choice is just one shot, no, of
I mean,
supratarsal.
can we give methylprednisolone instead of tricot, because tricot is obviously the drug of choice, but there have been cases where methylprednisolone has also been given because of the because they have a shorter duration of action and the rise of IOP is also less. We can monitor these cases. But the tricot, it works for a longer period. So monitoring the IOP, particularly for kids, we cannot take them every time to an OR and then measure the IOP.
No, see, in the smaller children, if you aggravatively treat your allergy disease, the GPCs continuously disappear. It is the very long chronic cases in slightly early which stays and it doesn't go. In these cases, if you are going to take the trouble to put the child under GA, evert the lids and get to the supratarsal space, why not a tricot? Because commonly, I have not seen some glaucoma in these patients,
Yes.
because of a supratarsal thing.
We have that IOP factor in our mind.
We are being more careless and randomly using topical steroids more. I think if you're going to maintain your child on cyclosporin and tacrolimus and you're giving it for those obliterating or the non-resolving GPC, then if you're going to take him to the OT, you better give a tricot.
Thank you, ma'am. Ma'am, this is for the benefit of the PGTs. I would like to ask one question. I mean, it's open for all. How to differentiate, how to identify a papillae at the very early stage? Is there a clinical method by which we can identify the papillae before they are at the very early stage when they are very mild?
Kalendra, you can answer it?
Yeah,
would you like to answer this?
I want to say, but I could not. My audio is somehow not connecting. Is it coming now?
Yes, very much.
Yeah. So I just want to make one comment regarding the seal ulcer and giant papillae. What I did in few of the patients is that first maybe scrape off the border of the seal ulcer, and then I give injections, subtarsal injection, triamcinolone in multiple punctures around the follicles, along the papillae, and then of course I wait for some more time. If it doesn't get reduced, then I take a 60 or 80 Vicryl and then tie the root of the follicles, and then after a few days it falls off by itself. So because previously I did few cryo in some of the patients, but cryo gives rise to lots of inflammations and lots of liberation of pigment on the ocular surface. So it is not a very good alternative. So in seal ulcer, especially in medical situation, apart from scraping of the base and margin of the ulcer, then I directly go and hit the giant papillae with the triamcinolone steroid, or maybe local tying up of the root of the papillae so that it falls off by itself. So that one in case of severe cases that I used to do.
Does it irritate when you tie it up? Doesn't it irritate the eye more?
Actually, cryo does lots of irritation, but if you
tying up that you said.
Yeah, the child of course has to be under general anesthesia or like sedation, and you do the procedure in the operation theater. I did few of the patients, especially in very hopeless situations where nothing works well. So in those kind of situations, this treatment helps in some of the patients. Especially
in
case of recalcitrant seal ulcers. With
post-operatively, did the patient have too much of irritation? During the process, we know that the child is under anesthesia, but post-operatively, sir, how much time it
Yes,
takes for the
initially,
follicle to form?
post-operatively also, as you said, rightly said, that we give oral steroids as well as topical steroids. I use lots of tear substitute mixed with auto serum. Patient's own blood is taken, serum is extracted and mixed with the tear substitute. I use a lot of tear substitute, auto tear substitutes. And then, of course, the cyclosporin as such in this type of patient immediately following the procedure will be little irritating, but steroid is okay. And tear substitute, both in the form of a drop as well as gel, it works well. So that is my experience in some of the patients which are very bad and very recalcitrant type, who doesn't respond to normal conventional therapy.
Kalyanda, most of these cobblestone GPC, if you see, once you evert the loop, you just have to shave off those cobbles. It comes off quite easily. And then, if you put your tricol and we put an amniotic membrane, now that we have glue, we don't have to stitch it also. We just put it, then remove your shield also, put a BCL. It does one. Wonderful.
What I was trying to tell is that I put a knot and then pass it over the.
Won't it irritate the patient post-operatively?
No, just tie it and then cut through the thread near the root of the thing, and it falls off by itself after a few days. I do not go and directly cut because cutting itself will expose the tarsal surface, and maybe it will cause more. Sometimes it causes a little bit of bleeding, and so the patient gets a little bit apprehensive. So if you do that, that was my. I did few patients like that, and then there is no bleeding, nothing, and it easily gets better by about 1 week or 10 days time.
Ma'am, what is your experience on, mucous membrane grafting with the GPC patients?
No, I've not done mucous membrane grafting for that because for us to do it in private practice, it's a lot of preparations, I have only done it in SJS case, but not for VKC.
Any more questions from the audience or the panel?
Ratna, any questions?
Can I say something?
Yes, sir.
So, Arundhati has nicely presented. As most of us are clinicians, that's why we are mostly concerned with different morphological types and what we do. Actually, the subject is our itchy and burny eye. Itchy, definitely it's more common in youngs and it's allergy, and burny is most common in the adult youth group, different causes, mostly the dry eye. Now, our understanding when we were student, at that time also it is the same thing, muscle, histamines, same thing, because our understanding, molecular understanding of the itching and burning is still very primitive. If you see the other branches of our medicine, suppose for example bronchial asthma, the clinical patterns and the mortality is increasing day by day. And most of the allergists or immunologists, they are not preferring steroids. Rather, they are going more on the biologicals because they almost are trying to understand the pathology behind it. So, as we are used to the same type of drugs, means steroids and mast stabilizer, antihistamine, because we don't have much options, because we have to use that in different permutation and combinations, and we know the different complications associated with steroids and all these things. So molecular understanding of the allergy, actually we need more evidence on these subjects. People are doing that, not by the clinician, but the molecular scientists are doing that. So till a conclusive evidence comes in, we will be confined with those different presentations of allergy. So many of, as Arundhati has said, that mostly the eye is a very delicate structures. If you put something there, definitely it will sense the surface and it will produce a lot of complications. As you can say, the mast cell concentration is the amount of endothelial cells in the cornea. It is full of cells, and how the antigen presenting cells they behave. So a lot immunological things, mostly what we are concerned with that, those are the innate immunity, the mast cell, lymphocyte, and all these things, kinins and all these things. But acquired immunity sets in when it is a chronic thing. So we have to find out new modalities of treatment, and hopefully in near future a lot of new things will be coming, because this problem, allergy, burny eye, is creating problem to the patients, to the clinicians. You can treat temporarily, it goes off, comes again, and nature takes care subsequently, because most of the allergy, they disappears as age progresses. So thank you all the panelists for giving us the informations of different molecules used in these things. We have to look into the different, suppose squamous cell carcinoma. Squamous cell carcinoma may be may present as a itchy or burny things. So we have to have a broader pictures. For some example, sarcoidosis. Sarcoidosis may present with a itchy burny eye. So there is a greater picture behind, because you can't consider eyeball as a singularly. It's a part of the body. As it is being exposed, it's a very delicate structure. The external allergens, they come and produce a lot of local reactions. We have limited things in our armamentarium. So gradually people are using systemic drugs, less glucocorticoids, because we as an ophthalmologist, we are used to use very high dose of steroids, but people are using lesser amount of steroids. And hopefully in near future, different biologicals will come, which will block that particular pathway of release of different amines, which produces all the inflammatory signs. So thank you, Arundhati, for your nice
Thank you, sir.
presentation, and Dr. Koilan, Swaraj, and Nilakshi for making this webinar a great success. Thank you, everyone.
Thank you.
Thank you, sir. That was quite informative, and thank you for enlightening us.
Thank you for the invitation. And thank
Thank
you for
Thank you,
the
Arundhati. Thank you.
So I think we have come to the conclusion of this webinar. So before we wrap up, I would request Dr. Abhijit Hendik to give the vote of thanks. Dr. Hendik, are you there? I think he is. Yeah.
Nilanjan is.
Yes, I am there. So it was a very fantastic presentation by Dr. Arundhati Bhattakur, and it was a very interactive session. Thanks to the chairpersons, Dr. Ratul Deka sir, Dr. Swaraj Bhattacharjee, and Dr. Ruma Das, and thanks to moderator Nilakshi for making it very interactive. Thanks to the panelists, Dr. Koilan Das, Dr. Hemanto Hajarik not here, and Dr. Arundhati Tamuli. And we'd like to thank Antod Pharmaceuticals. And we'll hope that we'll meet again in the future. Thank you all and good night.
Thank you.
Before just concluding, can I have a one line?
Yes,
We
yes.
all
Yes,
invite
yes,
to
sure.
the annual conference of the Ophthalmic Society of Assam
Tinsukia.
at Tinsukia on 21st and 22nd December. Is the slide visible? No.
Yes, yes.
Yes,
Yes, yes.
Please have a look and do plan yourself, and we must be all there together at Tinsukia. Thank you so much.
Thank you, sir, for the invitation. We'll be there definitely. And thank you all.
Thank
Good
you
night.
so much. Good night.
Thank you.
Good night.
Thank you.
There's nothing in the chat box, right?